One limitation is invisible. It may be caused by liver characteristics, such as fatty liver or liver cirrhosis. Another is tumor characteristics, such as isoechoic tumor. Another cause is tumor location. For inferior S3 lesion may be masked by bowel gas. For upper segment 7 or 8 lesion may be masked by lung gas. Another limitation is inaccessible lesion, such as obese patient with deep located lesion. And another is the lesion interfered by bone, lung, or bowel gas. There are some solutions for the ultrasound limitation. One is artificial ascites or bright fusion. For this case, it can make the lesion more clear and avoid the injury to the diaphragm. Another solution is application of contrast agent. For this lesion, in anterior phase, the tumor is bright up, and the pupil phase hypoechoic, so we can clearly identify the lesion. Another solution is assistance of fusion image. We can make the lesion not clear in ultrasound, but clear in CT, and the fusion, we can easily identify the lesion. The last solution is combine lipiodal TA with CT guide IFA. I will discuss it later. However, there is still a limitation of the solution, such as if the patient after operation, the adhesion will limited the artificial ascites, it cannot successfully separate the liver from diaphragm. And for contrast enhanced ultrasound, the time limitation for multiple or large tumor, it is not easy to complete ablation. Cannot see the tumor all the time. And another limitation is when we use fusion image, when the patient changing position, we easy to misregistration the lesion by ultrasound guide. So all the limitations can be solved by the combined lipiodal TA with CT guided tumor ablation. The benefits of lipiodal TA including lipiodal can make hepatic tumor conspicuous. It can serve as a positive contrast agent for hypervascular tumor and serve as negative contrast agent for hypovascular tumor. And it is possible to detect additional lesion. And the durability of lipiodal retention is much longer than contrast and ultrasound. It can last for hours or even days. And it usually do not misregister tumor even when changing patient position. And it has a very good demarcation of 3D safety margin. And because after lipiodal TA, it can decrease the heat sink effect. For this lesion, the hypervascular HCC in anterior phase was well enhanced. And after lipiodal TA, there is dense lipiodal retention in the tumor. And it is also see additional lesion just right anterior to the lesion. And the durability of the lipiodal can make we have another time to ablate the tumor. And because lipiodal retention tumor, we can see the tumor margin and we can see the hypodense ablation zone. So we can clearly demarcate 3D safety margin. For this lung cancer metastasis hypovascular tumor, we can see two hypodense lesions in right lobe, but not one of it is not clearly seen in the photo frame space. After lipiodal TA, we can see these two lesions was hypodense, and we can clearly identify the tumor and ablate these two tumors simultaneously. And for the tumor after previous TA with a recurrent tumor, and we perform lipiodal TA, and there is dense lipiodal retention in the tumor. We change the position because the tumor is contacted with the colon, and when we make the patient right side up, we can separate the tumor from the colon and can insert the ablation electrode precisely into the tumor and avoid the injury to colon. And the benefits of CT guide are including 360-degree approachable. we can approach from anterior, right, left, or posterior, or from inferior to superior, even superior to inferior. And the CT guide will not be interfered by bone, fat, lung, or bowel gas. It is available for this patient. We can choose a suitable trajectory route for electrode insertion. And we can precisely see the IV electrode tip during IV under CT guide. And usually no need of artificial ascites or perfusion. And it is easy to reposition the electrode for overlapping IV because the CT will not be interfered by the gas formation after ablation. And it is easy for placement of multiple electrodes. For this case, we can approach from anterior, from right, from left, or from posterior. For this region is very high, so I enter from very inferior with a steeper angle to the region at the right superior level. And for this region, it is retrocardiac region. So if we approach from anterior, there is risk of heart injury. So I approach from left side. And under CT guide, we can precisely see the tip of the electrode for this lesion very close to the heart. And we can see the tip of the electrode to avoid the injury to the heart. And for large tumor, we can place 3 electrodes simultaneously at equal distance each other and parallel each other. And the center one is a biopsy needle. So the technique of combined TA and IFA is I usually perform TA at first. Usually I use low bar or whole liver dispersion of the epiodome. If the tumor stain is not clear, I will sugar select the TA. Or if the liver function is limited, I will also use sugar select TA. The CT guide IFA usually perform at the same day or 2 days after TA because of my schedule. Another technique is the off-plane approach. If the lesion is just posterior to the vessel, if we want to avoid the vessel complication, we must be familiar with the off-plane approach from inferior to superior to approach the tumor. So I will show some challenging case under this combined treatment. The first is a substantial lesion, S3, just right beside the duodenal barber, and the superior to the gateway entrance. After epiodal TA, there's dense epiodal retention in the tumor, and I insert the balloon catheter to separate the tumor and the adjacent duodenum and the stomach, and inflate the balloon with air, and insert the electrode from left to right to the tumor. And after ablation, the tumor is completely ablated, and no injury to the duodenum or stomach. And another lesion is, I showed before, just adjacent to the colon. After insert the ablation needle and the right side up position, and separate the tumor from the colon. After ablation, 6 months later, the tumor was completely ablated, smaller size, and no injury to the colon. Another issue is tumor adjacent to the bile duct. This is the tumor after previous TA with partial epiodal retention, but still viable tumor here. So after TA, I inserted EMVD and infusion with ice normal saline to protect the bile duct, and insert the ablation electrode anteriorly. After ablation, we can see epiodal retention in the tumor, and the ablation zone is hypodense, completely cover the tumor, and no dilatation of the bile duct. So we very successful and safely treat the tumor completely. Another choice for the lesion near bile duct is cryoablation. This is premorphist MRI. We can see the tumor just posterior to the right, IHD and the CHD. And after the epiodal TA, we can clearly see the tumor, and insert the cryo probe from inferior to superior. And 6 years later, The tumor was completely ablated and smaller in size, and the bile duct just limited to segment 8, mild dilated, no other injury to other bile duct. So for bile duct, near bile duct lesion, we can do choice EMVD with ice normal standing infusion or with cryo or ablation. Actually, there's a third choice is IRE. For S1 HCC between large vessel, the tumor between portal vein and IVC and with indentation on portal vein and IVC. After the pivotal TAE, we can show density pivotal retention in the tumor, and I used only one electrode, so the first position near IVC and another position very close to portal vein, and 1 month later, complete ablation of the tumor and no injury to the major vessel. And this is also cortical lesion, but it's metastasis from colon cancer. It is Professor Rim, so-called non-active tumor. So for this scenario, I use 2 electrodes to the tumor because it is metastasis. So after the pivotal TAE, it is hypodense. And 22 months later, the tumor was completely ablated and no injury to the adjacent vessels. And so for cortical lesion, I usually use 2 electrodes, and if only 1 electrode can be used, I usually as close to the larger vessel as possible. And for the liver bone near diaphragm, the tumor here, after the pivotal TAE, there's density pivotal retention here, and I use off-plan approach technique from inferior to superior, and precisely insert the tumor to the tumor. After ablation, 2 months and 8 months later, the tumor was completely ablated. No injury to the diaphragm, lung, or heart. And this is extreme case. Liver tumor was completely treated, no tumor in liver, but there's enlarged lymph node in the principal foramen here between pancreas, duodenum, and the large vessels. After ablation from extraduodenal artery, there's density pivotal retention in the lymph node, and because we can see a window between liver and the right kidney here, and I make the patient in decubitus position, and enter electrode from here, and to ablate the tumor. After ablation, we can see the pivotal retention in the lymph node with density, and the ablation zone completely cover the lymph node. No injury to adjacent vessels and the bowels. For large tumor, this is a 7.2 tumors, very large, and after the pivotal retention, we can precisely place 3 electrodes to the tumor parallel each other, and with 1.5 to 2 centimeter spacing each other. And after ablation, 3 months later, complete ablation of the tumor. So in conclusion, combining pivotal TAE with CT-guided tumor ablation is complementary to ultrasound-guided IFA. It can make tumor feasible and durable pivotal retention. Maybe we have another time to ablate the tumor, and it is accessible by CT guide. We can 360-degree approach the lesion, and we can precisely see the tip of the electrode, either metal or ceramic tip, or some microwave. And the combined pivotal TAE with CT guide and tumor ablation can treat most of the challenging